And ultimately, Prof explained to me that, the only way to get things perfect is to turn the clock back. Invent a time machine and go back and treat them before they developed any of these malocclusions, any of these airway issues, deal with the root cause. And that really is what brought me to early interception, early intervention orthodontics. So it was only when I became successful with my practice that I started to share my work in meetings and in lectures that I came across the understanding that the orthodontic community actually does not champion early interception anymore. When we use functional appliances, we know we don't get favorable outcomes predictable, right? It
Mhm.
moves teeth around, but skeletally, there are no significant changes.
Mhm.
Well, when I studied with Peter Buschang, who was the previous head of Texas A&M,
Mhm.
he did a lot of work in revising Bjork's work from the late 60s on true mandibular rotation, true mandibular and true maxillary rotation, um, the growth and development of children from early years into their late teens. They realized that uh, chin development, jaw balance development, airway development, room for wisdom teeth development
Mhm.
was a outcome of strong posture.
Hi guys, good afternoon, good evening, and good morning all over the world. My name Dr. Win. Welcome to my podcast today. With me, I have on the other side Dr. Simon Wong and his brother, the head of the enrollment class for early interceptive intervention for orthodontists, postal orthodontists. And I'm excited to have both of them here. Dr. Wong, how are you doing today?
Hello, Loc. How are you? Thank you for inviting me. I'm actually talking from the future. I'm in Melbourne. It is 8 a.m. on Friday, the 25th of April. So I'm from your future.
Absolutely. Kian, how are you today?
Hi, Dr. Wynn. Thanks for having us join. I know this is mainly a dental podcast. I'm just been helping with you interacted with me initially and connected you with Simon. I'm handling all the business, enrollment side of things for our educational program. So I'm going to let you guys have a conversation. And near the end, I'll rejoin and share a bit about, this upcoming 2-day introduction to early interceptive postural orthodontics in June. All right. So have fun. I'll leave you guys
All
to it.
right. Thank you very much, Kian. Uh, well, it's my honor. It's my honor and privilege to get to know Dr. Simon Wong today. The topic going to be is about early intervention in orthodontics. And those of you who are doing dentistry and then doing braces, whether you are a pediatric dentist, orthodontist dentist, a lot of us, including my friend, my college friend, whenever we talk about early intervention, we scare, we don't want to talk about, we don't want to do anything with kid. But this is a very interesting guest on my podcast today, Dr. Simon Wong. He loved to tackle the difficulty, which is handling the kid from 3 years old all the way to 10 years old. And that is his focus in his practice. And today, Dr. Wong will explain to us what the reason behind that is have no problem of handling these kids and helping them out for their future facial growth. Dr. Wong, before we go farther, just want to thank you that you spent some time today in the morning in Australia on the day that you have a time off today on Australia national holiday.
Oh, thank you. Thank you. Yes, today is Anzac Day in Australia, so it's a Remembrance Day for the First World War vets from Australia and New Zealand. So a shout out to the men and women who help to preserve the freedoms that we enjoy today here in the West. Okay, so
Wonderful.
yeah, I'm a general dentist. My practice is focused predominantly on early intervention, early interception. I treat children from around 3 all the way to about 10 years of age. This has been my primary focus probably for close to 20 years now. This is my 35th year in dental practice. And for the first half, it was a restorative-based general dental practice. A lot of cosmetic and full mouth rehabilitation, American Academy of Cosmetic Dentistry, Dawson. So those principles that really focused me on creating ideal occlusions. Occlusion was a very important part of my Dawson training, and that led me to the hurdles that sometimes as restorative dentists we can hit, which are TMD related issues.
Right.
When I refocused on, what happens 5, 10, 15 years after your rehabs, and often you get breakages in the porcelain, and often you have the materialization of TMD.
Right.
In my studies of TMD, I realized that it was intertwined with sleep and airway.
Wow.
So this understanding kind of brought me to the realization that, as a restorative dentist, we're dealing with the long-term outcomes of a lot of health-related issues.
Right.
And as a restorative dentist, I wanted to, how do we get this as good as possible? How do we get this lasting as long as possible? And ultimately, Prof explained to me that, the only way to get things perfect is to turn the clock back. Invent a time machine and go back and treat them before they developed any of these malocclusions, any of these airway issues, deal with the root cause. And that really is what brought me to early interception, early intervention orthodontics.
So before we go farther, I just want to go over quickly. Dr. Simon Wong graduated in 1991 at the University of how do you say it? Melbourne, yeah.
In Australia.
And in Australia, and he's a founder of the Early Intercept Posture Orthodontist. This means that we treat only kids around less than 10 years old. He's a co-author of the Good Oral Posture Exercise using the principle of facial growth guidance. And he's a diplomatic and fellowship of multiple organizations. It's a chief doctor at the Natural Smile Center in Australia. Focus on strictly kids less than 10 years old, taking care of the facial, cranial facial development and malocclusion correction. He's a world leading expert in facial growth guidance. It's called the orthotropic. A lot of those people, especially those who don't do braces, the term orthotropic is really news to a lot of people. I hope he's going to touch on a little bit about that. And he also have done more than 100 of cases that finished with evidence base and still in the research state about the early intervention care. And he's also an author, international speaker, and feature. He's featured on Netflix of the Open Wide documentary. I would love to know a little bit about that as well, Dr. Wong. So let's go back and how did you get yourself involved with early kid treatment, because this is this concept where even me and myself are doing braces for 15 years, but I don't want to deal with kid. But you are focused on the opposite of where people hate most. So I would love to know more. My friend and who've been doing same time with me braces, they are dying to know about exactly how in the world Dr. Wong just focus on early intervention. And this is really something the news for us. So please share with us.
I guess ultimately, we're here to treat from cradle to the grave. Yeah, that's
Yes.
the lifespan of a human being, and that's the healthcare that as dentists we are here to provide.
Yeah.
So we know that um, in general dentistry we have an umbrella coverage for that entire lifespan, but dentistry is so complex, it's so long spanning, so many disciplined in areas that we all end up doing what suits our personalities and our characters and our desires.
Right.
So, we find the sweet spot that we like to work in, and various specialties have materialized over the last 100 years to help dentists focus. We know that there are geriatric dentists, there are general dentists, there are periodontists, there are endodontists, there are max-fac surgeons, there are oral medicine doctors, orthodontists, pediatric dentists, and each of us kind of focus our attention on the age group and the issues that are most pressing and most appealing to us. When I was in the first half of my um, career, what appealed to me was cosmetic dentistry, full mouth rehabilitation. But that journey led me to understanding that in order to preserve the work that I had created, I actually needed to address the reason why things were breaking down. And airway disorders, TMD disorders, they are intertwined with malocclusion and bad growth from early childhood. So, chasing the rabbit down the hole brought me to an understanding that I needed to deal with the root cause. As clinicians, we have a medical model to follow, right? We look for symptoms, we look through the history, we do our evaluation, we do a provisional diagnosis so that we can organize the tests, x-rays, studies, um, charting, photographs, records that help us understand. Then we make, provisional diagnosis, we test them out, we work out a diagnosis, we look at what the root cause is, we look at goals, treatment plans, we execute, then we follow up, and then we, determine what the maximum medical intervention steps have been reached. If you want to cure a problem, you must know what the root cause of the problem is. So I started to focus all my attention on root cause. What's the root cause of malocclusion? What's the root cause of sleep disorder breathing? What's the root cause of TMD? And it just kept bringing me back to issues of development, environmental factors that affected early childhood development. I came across the teachings of John Mew. I came across other early intervention practitioners, and I started to study their work and joined in this understanding that airway and early intervention, airway and TMD, airway and malocclusion, it's a topic that is a very popular topic at the moment, right? Airway dentistry. I came across this 25 years ago by Professor Steve Olmos. So he created an amazing program that interlinked medicine with dentistry. And so that piqued my interest in early interception, early intervention.
Can you repeat the doctor name again?
Steve Olmos.
Steve Olmos.
So he created a program that helped us understand the connection between sleep breathing disorder, temporal mandibular disorder, and malocclusion.
Mm.
So that forced me to learn to deal with children. See, when I first started my practice, I realized, ironically, I don't particularly like treating children.
Right.
My practice for 10 years had an unspoken policy, no children.
Mhm.
Right? We only treated baby boomers who needed full mouth rehab and cosmetic dentistry. Right? This is all the Dawson training, the American Academy of Cosmetic Dentistry training. Right? But when I realized that this requirement for the rehabilitations was from root cause problems that stemmed from early childhood, I realized that even though I don't like treating children, if I want to deal with the root cause, I have to go back to early childhood dentistry. So I forced myself to learn techniques that would enable me to work with often uncooperative younger children.
Mhm.
We as human beings have immense capacity to learn things that are not innate to our nature. We can train ourselves to do things that just don't make any sense naturally. And that's just one of the things that I did. I developed passion for understanding many decades ago. That's part of my personality. And when I realized that I could understand the developmental process of children and how it interconnects with malocclusion, sleep breathing disorder, TMD, um, dentistry, then I had the motivation that I needed to learn.
Wow. So your mentor were John Mayer. Dr. John Mayer is the main doctor, or Dr. Stephen Olmos that is
I've been fortunate that I've been practicing dentistry for many decades, and I
Mhm.
have been very fortunate that I've had mentors of many periods throughout my career.
Yeah.
I had cosmetic dentistry mentors. I had Steve Olmos, who helped me understand sleep disorder, sleep breathing disorder, TMD, John Mew, Buschang.
Mhm.
These are mentors who help me understand interceptive orthodontics.
So in real quick is most of us, like as a general dentist or even a pediatric dentist, they just feel like it is impossible to have something put into the kid around 3 years old, 4 or 5 years old. How do you do that? Is this mostly just case selection?
Yeah, it's a combination of case selection and technique. All right. So there's a field of dentistry called pediatric dentistry.
Mhm.
Right. So a lot of psychology. Obviously, a lot of pediatric dentistry today is done under general anesthetic. Right.
Right.
So it overcomes some of those limitations.
Mhm.
But you work with the parents, you work with the children. Not every child is suitable. Not every child, not every parent has the maturity to be able to cope with the compliance-based therapy. The interceptive dentistry that I do for early intervention orthodontics
Mhm.
is compliance and removable appliance-based.
Okay.
Right, so we very rarely use any form of fixed appliances. It's predominantly removable appliances. And it is the focus on growth and development. So um, movements, function, posture. We select families who have sufficient discipline and willingness to teach their children to overcome. All right.
I
So,
see.
like all parents understand, um, all human beings understand. Most of what we do in our life, we don't particularly like.
Right.
Right? The majority of our day is dealing with things that we don't like.
Hmm.
We have 4 weeks in 52 weeks where we choose to do things that we're super happy about, right? And
Right.
then we got 48 weeks of the year where we just try to get through so that we can have the 4 weeks vacation,
Right. Right.
right? So life is just learning about dealing with things that we don't like and then making the best of what we have.
So the curiosity that we have is like for dentists like me or other friend, we like to take easy stuff. Like we don't want to deal with difficult kid like that. For in your practice, I guess it takes so much time to build up the practice where you are now. But at the beginning, it's so hard because you are pretty much narrowed out the small group of kids around that age, and you have to not only get to know the parent, take so much time to get to know the parent, take so much time to see whether this candidate fit on your practice. um, it's very opposite with what typical dentists. We want easy. We want more people come in, take care, quick, go home, bye bye. But for you, you are setting up a very small niche type of patient, and you have to not only formulate that, but you have to deal with individual family. It takes a protocol to get that. So
Yeah,
it's a,
absolutely. So, but what I realized was my practice is very different to general practice, but my
uh,
practice is not that different to my previous cosmetic rehab practice.
uh-huh,
Right? All right. When a typical day as a general dentist would have been some root canals, some extractions, um, some, maybe one or two crowns, lots of fillings. Yeah, that's a typical
right,
day. Yeah.
right.
But then my previous practice was in the morning, I would do a rehab. I might cut 20 crowns.
Uh,
In the afternoon, I'd do consults. I might do, 3 unit bridge. Might do some night splints. Okay, so that would be a typical day,
mhm.
right? So that's very different to, 2 crowns, 2 extractions, 5 fillings, and 2 root canals, right? Like
Right,
when you're cutting a 20 unit rehab, you have a different practice.
right.
Um, the skills that I learned for high-end restorative dentistry translate very easily to any form of specialized therapy.
Right. But what I'm saying is did it take a long time to build your practice the way it is right now?
Yes, it took a few years.
Hmm.
The transition period happened very gradually.
Hmm.
I maintained my general practice for many years after I made the decision to refocus my energy, and everything is juggling. About probably 9 years ago, I made the final transition, and I've made the decision just to focus on children. I had developed techniques and protocols, as you explained, that helped me uh, curate families that were compliant. I developed a program called the Good Oral Posture Exercise Program, which is a compliance-based um, lifestyle change
Hmm.
that helped me screen families and children for compliance.
I see. And I think from my understanding, you put that protocol or guideline for everyone who want to use it, right? Everybody, the good exercise posture Um,
Well, all things that we do in life require practice and training, all right, if we want to be good at it.
Mhm.
And my study in posture, my study in early intervention, it distilled an understanding of the root cause of airway disorder, root cause of TMD, and the root cause of malocclusion. And it kept coming back to work that was published as early as the late 70s by William Prophet. Right? He talked about the equilibrium theory. He talked about the difference between light continuous forces versus strong intermittent forces. Right? So he distinguished the difference between posture and function. And because of him, companies developed orthodontic wires called nickel titanium wires. Right? So we know there's a difference between nickel titanium and stainless steel. Right?
Yeah.
Prior to the late 70s, it was all stainless steel wires. All right, all the forces that we had were intermediate and strong. And yeah, it moved teeth, but didn't move them anywhere near as efficiently and as effectively as light continuous forces when nickel titanium was developed. So we know that um, biological change is slow and long acting. We know that functional movements are a physical push that we can't resist. So we're bodily moved in space. When I realized how significant posture as opposed to function was, it cleared up a lot of the controversies in my mind as to why early intervention using functional appliances has been found wanting, but modification of growth and development by focusing on posture has been consistently successful.
I see.
So I realized when I was studying posture, which is advocated by William Prophet and John Mew in his postural basis of malocclusion, he developed orthotropics. So orthotropics is what he deems to be a term for correcting growth. I learned that in the last 20 years, early interception, early intervention has gone out of favor. It is no longer practiced in the orthodontic specialty. There were research studies, very powerful, high-level, level 1 evidence-based research, large multi-center randomized control trials that were done in the US and the UK. Prophet and Tulloch ran the first big study, 2004, and they were looking at comparing two-phase treatment using functional appliances and then fixed braces compared to only phase 2, which was fixed braces in the teenage years. They tried to evaluate how successful early intervention using functional appliances was for class 2 correction. And unfortunately, they found there was no evidence to support a two-phase treatment. It did not give an outcome that was of any significant difference compared to just putting braces on in the teenage years. O'Brien in 2009 followed up with a specific randomized control trial, again, large multi-center. These are two of the biggest randomized control trials ever done in dentistry. So he tested a twin block, which was the functional appliance that most commonly used in the UK at the time. They tested the treatment on Division 1 Class 2 malocclusions, and they found that all the outcomes were purely dental alveolar. There was no skeletal changes.
Mm.
So those, I suppose, landmark trials and papers cemented in the orthodontic community's minds that early intervention, skeletal correction was not something that was predictable nor viable. And so from that moment onwards, it did not make sense, based on the evidence, to treat early and to certainly use functional appliances and to certainly treat prior to the teenage years. So that was the main shift in the focus. Prior to that, everyone did early interception, everyone did early intervention. But dentistry is evidence-based, right? It's something that must rely on studies and research to define the standard of care practice. What I did in the early part of my orthodontic focus was not so much learn about evidence bases and research and study, but I just followed my mentors, right? My mentors said, oh, use this, use that, try this, try that. And when I followed the recipe, I got results. I got amazing results. And I thought, this is just the most amazing thing. And when I started to speak about this in meetings, people said, oh, no, you don't realize all these changes are dental alveolar. We've got studies that show this is hocus, this is made up, right? You just got lucky. So it was only when I became successful with my practice that I started to share my work in meetings and in lectures, that I came across the understanding that the orthodontic community actually does not champion early interception anymore.
Right.
And then I started to research why. Why was I getting results? Why are we being taught that this is a false hope? And that's how I came across the research. But I also came across other research that supported the postural basis of malocclusion. Right? When we use functional appliances, we know we don't get favorable outcomes predictably. Right? It moves teeth around, but skeletally there are no significant changes. But when I studied with Peter Buschang, who was the previous head of Texas A&M, he did a lot of work in revising Bjork's work from the late 60s on true mandibular rotation. True mandibular and true maxillary rotation. The growth and development of children from early years into their late teens. They realized that chin development, jaw balance development, airway development, room for wisdom teeth development was a outcome of strong posture. Peter Buschang developed techniques in the early 2000s that coincided with his publication of work on posture and its impact on true mandibular rotation. And they found that when they used very complex protocols, they were able to correct hyperdivergence, which is vertical growth in young children. And so we know that although using functional appliances, we don't get skeletal correction in growth and development. When we focus on vertical, when we focus on posturally based appliance therapy, we can actually change the direction of the rotation of the mandible. So that is what has shifted my focus now, not so much on functional appliances, but on postural orthodontics. So I developed protocols that focused on posture. So it's long, light, long and light forces rather than intermittent heavy forces.
Can you repeat long life? So can you give an example, like what exactly the protocol is, that force that you're talking about versus the force that someone else work on?
Well, chewing, for example,
Mm-hmm.
right, is a functional activity.
Mm-hmm.
The forces are very high, right? They're very short lasting. Yes.
Yeah.
So, we can load the masseter pull in a fully grown male can be almost a ton, right? Why do people break teeth? Because they're loading in function at a far too heavy action, right? So chewing is what we call a function. Resting posture is resting position is a posture, right? Where it's long, light, continuous. Okay. So when you're talking, you are in function, and predominantly you will talk only for a few minutes or a few hours a day.
Yeah.
When you aren't talking, you are at rest. That's the postural position. And you're holding that for the majority of the day. All right. So another example is you're awake for 2/3 of the day. 3/4 of the day you were awake.
Yeah.
For 8 hours of the day you're asleep. Okay. So when you're asleep, you hold a still position, a postural position. When you're awake, you're moving around in action, and that's called a functional action.
Is there a huge different what young kid would do that would affect their growth? Can you give us a couple of examples, like in your practice, if you see the kids have problems?
So when we learn of why functional appliances don't work, but why Buschang and Muse postural appliances work, we realize that when we're exerting active force, a functional appliance, like class 2 correction, right? Class 2 mechanics works by opening the mouth and pulling on the elastics, yes? When your teeth are together, your class 2 elastics don't work. Right? There's no force. Okay. When your teeth are apart, your class 2 mechanics pulls the top back to the bottom and the bottom forward to the top, yes?
Right.
All right. So one is the resting position, which is either mouth closed or mouth open, and one is a functional pull. Okay? So we know functional mechanics doesn't work. It helps equalize the dental position, but it doesn't change the skeletal position. It doesn't change the skeletal form. But we know through Bjork's work, we know through all the work done on hyperdivergence, right? Adenoid facey children, children who have got big adenoids and tonsils, who have to breathe through their mouth. Their resting posture is mouth wide open all the time. We know through Bjork's work and through Peter Buschang's work that If you have your mouth open, your chin rotation is what we call a down and backwards rotation.
Mm.
Right? When your mouth is closed, we know that the pull force of the elevator muscles drives the growth and development upwards and forwards.
Mm.
Upwards and forwards growth provides width and depth and reduces the height so that the teeth are well aligned, the jaws are in good balance, the chin is a strong position, and the airway is nicely opened.
Mm.
When the mouth is open all the time,
Mm.
we know that there's increased vertical, there's a collapse in transverse, AP in particular with the chin is set back.
Mm.
So there's a constriction of space for the airway, for the tongue, for the teeth. And in fact, you end up in a situation where the front teeth don't even meet together.
Yeah.
Right? So an open mouth posture drives excessive vertical growth, but a closed mouth posture drives strong forward growth.
Mm.
And we know forward growth is always favorable to the airway and for the development of space and for strong AP position and class 1 relationships.
Mm.
So posture, right, how you rest your jaw, how you rest your body is integral to how the body grows relative to our life here on Earth.
I see. So the more kids that have the let's say severe class 2 or severe class 3, they tend to have some other medical problem like
Yes?
ADHD, autistic, and other stuff. Do you treat those kids too in your office?
Yes. Yeah. So one of the things about airway orthodontics, airway dentistry, is that true airway orthodontics is not something that we as dentists do.
Mm-hmm.
Right? We do the orthodontic part,
Mm-hmm.
but the airway part is done by our medical colleagues. So true airway orthodontics is a multidisciplinary approach.
Mm-hmm.
Right? We screen for airway issues just as we screen for orthodontic issues.
Mm-hmm.
When we have airway issues
Mm-hmm.
in young children, we work out with our ENT and sleep physician colleagues
Mm-hmm.
what the primary care needs are first. What's the priority? If they have a severe malocclusion, there's a good chance their posture is very bad. If their posture is very bad, 9 times out of 10, it's because their nose is blocked, or their adenoids are enlarged, or their tonsils are overgrown. And these are the same children with the severe vertical growth and developmental issues. Vertical growth drives both class 2 and class 3. Right? Excessive vertical is in both class 2 division 1 malocclusions and class 3 high angle malocclusions. Right? These are the airway compromised children.
Right.
So when we find these children, we almost invariably find their nose is blocked, their pharyngeal space is blocked. As airway is a vital function, the first step always universally is refer to ENT, refer to sleep physicians, and have medical primary care managed first. Only when we have a stable health relationship do they come back, and then we treat for correction of orthodontic imbalances and retrain these children to improve their posture so that they don't relapse back into the same trend of growth that brought them their malocclusion issues in the first place.
Mm. So it seems like your practice is so in focus when you have the parent that have the kid that the it looked like people travel in different city come to your office because it's just a unique office that dealing with this group of kids, right? So it's not just like the kid that in town. It might be from other place they come to because they heard about what you do.
The most of the children are local to my
Okay.
practice.
Hmm.
The treatment runs 18 months, longer, 2 years, 3 years, sometimes longer. And the recall visits are frequent, much more frequent than the normal 6-week programs that are part of fixed ortho.
Hmm.
So often it's impractical for families who don't live locally. It's just the nature of the game.
Hmm.
Uh, but I have about 5 or 10% of my practice who travel many hours each time to come see me. Some historically have even been interstate, so it's not particularly practical.
Hmm.
But this is what we all know. Concerned parents will do almost anything for making the life of their children better, right?
Yeah, absolutely. Uh, we have maybe less than 10 minutes. This conversation that you can just sit here and talk a lot, and some of us look at you and like, what is he talking about? But for those of you listening and watching this conversation with Dr. Simon Wong, he is going to teach in June. Is that 7, 6, 7, Dr. Wong? On June this year, you have a.
Yes. So we have an online program, a 2-day introduction to early interception postural orthodontics.
Uh-huh.
Uh,
This
it
this is right
is,
there. Yeah.
I'll get Kian, who is
Yes.
head of enrollments, to go through that.
Yeah,
It's
absolutely.
Friday and Saturday, June the 6th and 7th of this year.
Uh-huh.
Yes, that's right.
Could
Yes,
you could
it's
you tell us a little bit about this class and also um, just what I'm excited is about the thing that you and these four other guests on the panel, they all have the same mindset and focus on early intervention. And so you're not the only person on earth that doing this, right? You have other people that are doing this, and it's been they've been doing this for years, for decades, and they enjoy doing this. And this is a passion. It's not about just a dentistry alone, but it's more like the passion of what you see the future of the kid, of the being adults. These kids gonna turn adults, and but if we able to help early in their life, things can be significant for their future in regarding to their intelligence, their mental health, and their appearance and everything. I'm sure you will talk a lot about this, and maybe you can also share maybe one or two case, a successful case story and things like that later on. But just tell us a little bit about this, Kian, about the date, upcoming
oh,
event.
yeah, absolutely. I'll just, if I may chime in. So it's June 6th and 7th. It's a Friday and Saturday in the US, from 2 p.m. to 9 p.m. Pacific. For those of you in the West Coast, like Dr. Wynn, um, it's Simon's morning time when he starts very early Saturday morning, but it's Friday and Saturday for us here in the US. 14 hours of CE through the Complete Health Group, the PACE program, AGD. So, there's some multiple choice test quizzes. If you want the 14 hours of CE verification, We have a number of guest speakers. Well, actually, the main guest speaker will be Dr. Kevin Boyd. He'll be joining us on Saturday. This is all through Zoom, so it is live streamed. Dr. Kevin Boyd will be joining us on day 2. Professor Narinder Singh and Dr. Amanda Wilson. She's an orthodontist from Hawaii. Professor Singh is an ENT from Sydney. They actually joined us in person last year at our 2-day event. We did this once a year, so this is our 6th annual 2-day intro. And we recorded the entire presentation, and we give it away as a bonus for joining. So those of you who want to enroll, it's April 24th at the moment as the time of this webinar that we're having. We'll be uploading it shortly. You can get instant access to last year's 2-day intro program. So you can watch, the special presentations from Professor Singh, Amanda, etc., and the core content, so that when you come June, it'll be like a refresher, So we have a lot of people who want to get access straight away. Now the pricing will be $1,500 in May. But we have a special currently where it's only roughly $1,200, $1,197. But for, which includes the recordings from last year, as mentioned, and over 500 pages of, detailed notes, protocols. It's not just an introduction. We've had over 500 people attend over the last 5 years, and about 6-7% are orthodontists. A small percentage, and Simon decided to give away the exact protocol. So we've got hundreds of pages of additional notes you can download, practice templates, sleep questionnaires, how to actually use these appliances, how to design them, how to communicate with the lab. So you can get literally started after the 2-day, if obviously you're very experienced like orthodontists. So it's very comprehensive. But we do have a special, because this is a special event here. Thank you to Dr. Huynh for having us as a guest. We have a special where it's just $297 up front, so you can get instant access to the recordings, and then a month later, you pay the additional $700. Right? So total is just $997. So we decided to give a small discount off the current pricing. And just email us, info@straightteethnaturally.com. It's info@straightteethnaturally.com. Mention, the Loc 19 special. As mentioned, we have a 30-day money-back guarantee. So you just, enroll for $297. Check out the recordings from last year. See if it's for you. If you find it's not for you, you get a full refund. If it is, just before the event, in 30 days, time, we'll charge that additional $700. So this total is just $997. So that's the special offer that we mentioned just for your guests and colleagues. So hopefully you guys can join us in June 6th and 7th on virtual live stream between 2 to 9 Pacific time. All right, there you go. And for allied professionals, whether you're a registered dental hygienist or a myofunctional therapist, etc., we have a very good special. It's roughly 70-80% discount, just one-time payment of $275. And finally, if you're not based in the US, email us at info@straightteethnaturally.com for country specials.
What a good deal, Kian. Thank you so much for my audience. I'm hoping that those of you who are following and watching this podcast today, there's a deal for you guys. So follow us. We're going to put a link on the video, and hopefully you find it very useful. For the question for Dr. Wong is, let's say those of us who are skeptical, Dr. Wong, what do you think we can, as a general dentist, what we should know, at least at a minimum amount, to help if we don't treat it, but we know something, how we can help the referral and things like that too. Can you just give the dentist a little bit of like the impact, how it can help. We can help the kid, because sometimes we see the problem, we don't want to ignore, but we can do something. Referral to the ENT and doctor that specialize in early interceptive care. Can you give my friend, my audience, a little bit of testimony, like how it's impact the life of other kids?
Obviously, dentistry and orthodontics is such a broad field. Not everyone needs to do everything. What we as dentists do is we are in constant contact with families, families within our community. So we see children who are 3, 4, 5, 6, 7, 8, 9 years of age. We see them routinely, right? Often as much as every 6 months, we will see these children. Our general care is to look after their dental health, their periodontal health, but we have the capacity to screen for orthodontic issues, and if we are interested in doing so, have the capacity to screen for sleep disorder breathing. In my program, my 2-day introduction to interceptive postural orthodontics, I go through the screening protocols that you can use, the medical histories that you can use, the simple screening processes that you can use in your general practice to flag issues such as sleep disorder breathing, ADHD, poor oral posture related issues. We have simple techniques that allow us to flag at-risk children for medical health, so that we can do a qualified referral to ENT or sleep medicine. Right. What we don't want to do is panic refer every child who walks through the door. Right? There are protocols that need to be met so that our referrals are evidence-based, or that our referrals are valid and qualified. ENT doesn't want you to send every kid who's got a blocked nose into their clinic. Right? ENT wants you to send children who have enlarged adenoids, who have enlarged tonsils, who've got enlarged turbinates. I train dentists to screen very quickly for those issues. And then there is a validated process for referral. When we have multiple flags for sleep disorder breathing, then we have validated protocols available to the general dentist that only take a few minutes for a qualified referral for sleep medicine, for a sleep study. So those are things that you can do as dentists, right? Yeah. And I teach those who are interested how to do this efficiently, effectively, without disrupting their practice. Now, as far as early interceptive orthodontics, you may not have an orthodontist or a pediatric dentist that you can refer to who is interested in early interception. If you feel that you want to broaden the scope of coverage in your practice, then you can start interviewing orthodontists and pediatric dentists who are in your area who do interceptive treatment. And when you find a like-minded soul, you can connect with them and say, hey, are you interested in me referring you children who are 4, 5, 6, 7, 8 years of age, who I suspect would benefit from early interception? And they'll say, sure, or they'll say, no, it's not what we do. And so it's a process of scouting out specialists in your surrounding area who have the same passion as you do. So obviously, a lot of people have asked, can they see my cases? Well, we have examples, and obviously, in the 2-day program, we spend a lot of time going through specific case examples. But if you open up my homepage
Uh-huh.
in my practice, naturalsmilescenter.com.au,
Mhm.
we have many of
Cases here.
my research cases. Right? So we've got over 100 cases that I've been following
Mhm.
for over 10 years in many of these cases.
Mhm.
And it's just a quick glance at the before and after outcomes.
Mhm.
These are the cases that I'm doing research with the University of Alberta and Texas A&M, and we're doing cephalometric analysis of these children. The changes that are visually seen through the photographic records caught the eye of the heads of department of Alberta and Texas A&M. So they asked for the cephalometric records, and for the last few years, they have categorized and traced um, class 2 and hyperdivergent cases within this cohort. And we're finalizing some of the data in write-ups, and hopefully we'll be submitting for publication in peer-reviewed journals shortly.
Super beautiful. Yep. Can't wait for you to do some presentation, present some case in those 2 days event. Love to see these.
Yeah, we'll definitely be going through in a little bit more detail about how we were able to achieve these outcomes using postural orthodontics and the protocols that I had developed to help.
Do you have to put braces on these case?
90% of my cases, I don't use brackets.
Can you guys
These
hear
are
that?
all
90% of his case, there's no brackets on, and it's look beautiful. This
we
is
use
amazing.
removable appliances, and we focus on changing the posture.
Wow. Also,
Right.
you have the lab, or you develop the special you need appliance and your lab use it, or
Yes. So we've developed specific appliances for this process. I work with a local lab. My technician is Enrico Di Giovanni. His lab creates the appliances that I designed.
Mhm.
And over the last 15 years, we've worked together very closely to kind of get um, appliances that help me to achieve my goals. And we offer these appliances to the dentists who join the program, and we teach them how to design and to implement these appliances to achieve hopefully similar outcomes to what I'm capable of.
so do you think that we have to use your lab, or we might have to some, as long as we understand the principle and we can get the same result if we get the local lab do it?
Oh, absolutely. Like ultimately, I'm teaching principle-based dentistry.
Good.
I'm teaching you the understanding of the concepts. I'm also providing you with the protocols and the appliances, and you're welcome to use as little or as much as you want.
Mhm.
We always recommend um, that you at least test out 3 or 4 cases with my lab,
Mhm.
Because then you'll get appliances to the specific specification that I use.
Mhm.
And then you're welcome to, go and use your local labs to manage future cases.
So it's
But
doable. It's doable if we are in US and the lab is in Australia.
yes. Well, our lab here ships directly to the US, so we work with US-based dentists all the time.
Okay.
Enrico runs his own laboratory. I'm not involved with that process, but the design protocols I created and I make available to him to supply to US or dentists anywhere around the world. But of course, once you understand what it is that you are hoping to achieve with my protocols, you can sit with your own local labs and create your own appliances. There's no patents on what we have created. It's open source. So I encourage dentists to interact with their community, to interact with their local laboratories, and get them made on your own doorstep. Hire a technician and create your own appliances. Many of the orthodontists that I've trained previously have hired staff specifically to make their own appliances in-house. And so
Good.
for those, Enrico has trained many technicians and many of the staff to be able to do that. So yeah, for sure. These are universally open appliances, right? There's no patents on any of what we do.
Dr. Wong, in case those doctors that really like love what they're hearing and they want to go deeper training, what is the how long would it be the training for them to be comfortable become a provider for these kids?
Yeah, so initially all I did was work with orthodontists and pediatric dentists. All right, that was my primary focus to shift the focus of our specialties.
Mhm.
What I realized after teaching, so we've been teaching postural orthodontics since 2000. That's the last 5 years. That those who have the greatest passion for early intervention, early interception, are dentists who are parents of their own young children and pediatric dentists.
Mhm.
I found that their orthodontic knowledge base was not anywhere near as extensive, of course, as a specialist orthodontist. So I revised my program to almost to a point where I'm teaching newbies, people who are very limited orthodontic skill sets.
Mhm.
For those, I developed an advanced module 1, an advanced module 2, an advanced module 3 to fill in the background foundation orthodontic processes. And then we opened up a mentorship program that runs about 18 months, where every 2 weeks we meet online and I supervise the management of treatment by the pediatric dentist or the general dentist who will be using my protocols, postural orthodontics, in early interception. So there is a fairly comprehensive online residency program that we offer that follows the 2-day introduction.
Okay, good to know. So those of you interested in this conversation, this topic and training, follow us and register for the can you put a slide again? It's June 6th to 7th of this year. We're gonna go through Zoom and it's gonna be the whole world. So I'm excited to look forward to this day and to enjoy Dr. Wong and his team for this beautiful teaching. Thank you so much for the time that you have with us today, Dr. Wong and Kian. Really appreciate both of you. look forward to that day. And again, if you register early, there is a good deal, a discount for those who join early. Register for this class. Thank you again.
Thank you so much.
Have a good one.
Take care.